Professor Paul Griffin, who's Director of Infectious Diseases at Mater, Associate Professor of University of Adelaide. So Paul, welcome from the far north reaches. Daylight saving hasn't stopped you getting involved, and so we've got about half an hour to talk and then open it up for questions. So thank you, Paul.
Hi, hopefully you can see and hear me. Please let me know if there's any tech challenges, and apologies I couldn't be there in person. It sounds like a great meeting and I'm disappointed to not be able to make it. So thanks for that introduction and the invitation to speak. I'm going to be, I guess, in many ways extending a bit on what we just heard, quickly going through the diseases, but I'm sure this audience is very familiar, so I'll deliberately go through that relatively quickly despite some busy slides, and then really focus on some improved vaccine options we already have, and as a way of potentially addressing some of these challenges, but also look to, what might be coming around the corner. And a lot of that was just discussed, so that's a useful segue. If I can get my slides to work. So some relevant disclosures. I have been the principal investigator on a number of clinical trials relating to some of these products, and also have served on some medical advisory boards, and of course part of the Immunisation Coalition very proudly. But the content of what I'm going to speak about is all my own today. So just starting with RSV, it's fascinating what's happened in the last few years. If we were to give this sort of a talk a few years ago, we'd basically say, we think it's bad, but we don't really know, don't know how much of it's around. Sorry, my slides are auto-advancing. Don't know how much of it's around. Be great to have something to do, we could do about it, but we don't, and let's move on. But of course, that's all very much changed as recently as over the course of this year. So just by way of background, the important thing about the virology of RSV is just to understand that it's got these surface proteins. I think most people know about HNN with flu and spike with COVID, but it's useful to know that RSV has this F or fusion glycoprotein, because that's what all of our interventions are targeting. So you'll hear about that when we talk about both our monoclonal antibodies as well as our vaccine options. And there are two types, two strains, A and B, and there is one vaccine that has both and one that has just one. So that's why that's there for context. And again, I think this audience will be familiar with what we've seen in terms of the numbers, big numbers this year, a sort of early rise and a big peak. And interestingly, of course, what happened with the COVID interventions in place with that flat line back in 2021. And just showing that in a cumulative fashion, just how quickly we rose above the past 2 years and have stayed well above that, of course, appreciating it's been reportable only for the last few years, so we don't have historic data of any significant quality. And if we break that down by age, again, everyone here will be familiar, most of those cases have been reported in our youngest age group there of those less than 5 years of age. I think this is a useful slide, both for RSV and flu as well as COVID, to show our proportion of positive tests. So we know a large proportion of people aren't getting tested at all. So a proportion of positive tests gives us a bit of an idea about activity. And this kind of shows what's happened this year. We've had significant COVID in the background, perhaps 2 waves, but again, not declining even between that to insignificant levels. Flu, a big peak as we might expect a few weeks ago, maybe months now. But RSV in purple at the top has been fairly steady at pretty consistent levels for some time. So even though it is obviously, of course, seasonal, it doesn't, again, go away to zero shortly thereafter. And just as an indicator of severity of those 3 viruses as well, these are our ICU admissions, appreciating the axes are a little bit different. It's not like for like. And RSV, fortunately, has declined recently, but you can see there, especially earlier in the year, very high levels or reasonably high levels of people in intensive care, even from that. So, one of the challenges, I think, is the underappreciation of the significance of RSV. And I think when we look at these sort of figures and the other issues, we can hopefully help alleviate some of that. Deaths, of course, RSV is the lowest of the 3, and it is predominantly in that older group, but you can see still very significant. So in children, I think people understand it's a very significant infection in young children. Of course, what happens is, most people get exposed very early and you get an element of protection from that. So your first few are bad, you then get RSV repeatedly over the course of your life. And then as your immune system starts to decline in function with immunosenescence, it starts to become more significant again. So in children, acute lower respiratory tract infection, #1 cause of death, and RSV is the #1 cause of that. And you can see in terms of the cost at the bottom, and this is based on some laboratory data that's a bit limited and old, but you can see a very significant cost. And I like to highlight that when we talk about the cost benefit of the interventions we're discussing a little bit later. To me, it would seem like a pretty obvious equation. So in healthy adults, as I said, most people infected repeatedly probably don't even know they've had it, don't get slowed down. And when I plugged in fit and healthy adult less than 50, that's the Google Images image that popped up. That's why I put that in there. But as we get over 50 and our immune system starts to decline in function and we accumulate comorbidities, then the significance of RSV does start to escalate very significantly. And you can see there some very high rates of mortality potentially. But the point that's often underappreciated is the impact on people's functionality, and a very significant proportion of people with RSV don't return to independent function for 3 to 6 months after that infection. So again, there's a lot of morbidity that's harder to track that is well recognized, that is worthy of prevention. Not a surprising list of risk factors for severe disease in children. It's things like prematurity, heart and lung disease. In adults, advanced age is perhaps the main one, but also heart and lung disease and immunocompromise and being institutionalized. So we know residential aged care is really the perfect storm for a lot of these sort of infections. They're readily transmitted, hard to contain, and obviously the residents there are nearly all very high risk of severe disease. Very busy slide, but just to show really for RSV, we don't have any management. Non-pharmaceutical interventions are effective. We saw that during COVID. So preventing transmission can be effective. We know that testing is important, and we're getting better at testing with black box PCR and even rapid antigen tests that include COVID, flu, and RSV. But management's supportive. And I think that's important just to highlight, because that obviously tells us how important prevention is if we don't have much we can do about it afterwards. So just quickly moving to the monoclonal antibodies, and this isn't a new concept. So we've had a monoclonal antibody for RSV for a long time. And again, busy slide, but really the details there are it had very limited use given it was expensive. It had to be given often. And so it was really limited to the most high-risk infants. So again, not a new concept, but with modern molecular biology techniques, that sort of a concept was able to be tweaked into a long-acting, highly efficacious antibody that now can be used in a vaccine-like strategy. So most people would have heard of this product being referred to as a vaccine, whereas in fact it is a monoclonal antibody, and I've just listed the details of the approval there. It is obviously approved in our country and in use in some states. So we saw first that WA approved this, which was fantastic. Here in Queensland, we followed, and it was for all newborn infants and medically at-risk children with some complex eligibility there about second seasons, for example. And then other states have successively followed, but unfortunately, it's not sort of universal or nationally consistent just yet. Evidence, and again, this is more just to sort of frame this. People are probably familiar. The New England Journal for the vaccines I'll speak about and the antibody have these great summary pages, which basically show high levels of efficacy and very good safety data as well. And that's indeed the case for nirsevimab. So the immunisation handbook now has a lot of detail on RSV. This outlines who should have it. And of course, there's a bit of a disconnect between who it's approved for, who it's recommended for, as outlined here, and who it's available for funding wise. So there's a lot of good information in the immunisation handbook now on all of the RSV products. But of course, there's a lot of challenges. And as I alluded to, the cost effectiveness and the funding for this is still a bit of a challenge, and some communication issues as well. Here in Queensland, though, a little bit of anecdotal analysis of data. We had a lot of children admitted with RSV this season, but not one of those had received this product. And again, anecdotally, the perception has been quite positive, although there was some communication challenges around giving people some advance notice, etc. So it'd be great if we could see this expanded. And then moving on to vaccines, again, a really exciting development. And it's not like we didn't try and make RSV vaccines for a long time. Shortly after its discovery in the 50s, there was a fairly crude attempt at vaccines that was, obviously appropriate at the time and caused a big problem that really set RSV and other vaccines back a lot, in that these vaccines did exactly the opposite of what we wanted. They caused worse disease in the vaccine recipients. And unfortunately, the little child on his grandma's knee there didn't survive that. But we understand enhanced disease now. We know how to prevent it, and we specifically design vaccines to not do that. And in fact, it's an important part of preclinical and clinical assessment of all vaccines these days. And so we are very confident that all the vaccines we use don't do this now. And the other thing was working out that F protein I mentioned at the beginning has two shapes. We had to keep it in the right one, and that took, again, some clever scientific discoveries to do that. And so that's why we talk about the pre-fusion F, because when it changes shape to that on the right, you don't get any meaningful protection. So that's why we have these two vaccines that are both pre-fusion F protein vaccines. And the differences are one has A and B, one has A, one has an adjuvant and one doesn't. Not useful to enter into discussions about which is better because, of course, no head-to-head trials, both safe and effective, as I'll show very quickly in a moment. And the one at the bottom, obviously, is also approved for pregnant women. Just highlighting there a little bit of a disconnect between who it's approved for and who it's recommended for. And I'll come back to that in a moment. And again, just to go through these very quickly, same sort of deal, excellent efficacy graphs. There are some adverse events, but mostly mild and short-lived, and what you might expect from a vaccine such as this. The other thing to highlight is just the numbers in these clinical trials, 25,000, so very large, high-quality clinical trials that demonstrated safety and effectiveness, as well as with the Brisvo. This is the bivalent, non-adjuvanted, and again, elderly population, 35,000 or so participants. Again, local reactions a little bit higher, short-lived, mostly mild, highly efficacious. The percentages will appear different because the actual outcomes measured were slightly different. So again, not useful to say one's better than the other based on those figures. And of course, excellent data in pregnancy. Challenging to do clinical trials in pregnancy because we have to make sure it's very safe before we even contemplate that. 7,000 maternal participants, and again, showed similar incidence of adverse events and was highly efficacious. And remembering that vaccination in pregnancy is kind of a 3 or 4 for 1. You protect the mother, so they're less likely, I guess, to become unwell and transmit to the baby. You get transmission via the placenta, but also some transmission likely via breastfeeding. So you get a lot of benefit from maternal vaccination, which is why it's such an important strategy. And of course, this was approved and rolled out earlier this year. This is the fellow who first received it, who goes on to talk about how happy he was to be protected. And recent updates to the immunisation handbook, and anything I show has been cut and pasted and is always subject to change. So make sure you do go back to the source of truth there. So updated there end of June, and then again, some caveats that things are sort of still being updated and reviewed and that not funded, which of course is our biggest challenge perhaps with this one at the moment. So here are the recommendations. Sorry, my slides are auto-advancing. And remembering slight difference between the approvals. So clear recommendation. That terminology is kind of now a little consistent with how the COVID vaccines are discussed. So recommended, very clear in that highest risk group. Consider and take into account risk factors in that younger group. And the recommendations there about pregnancy, but again, appreciating that some of the recommendations actually say to try and hold it back a little bit later. So perhaps 32 to 36 weeks is the sweet spot. And the Sevimab's recommended, but of course, access varies depending on where you're located at present. Just to show those conditions associated with increased risk, I'm not expecting you to read this slide very quickly. It's almost anything, and anything that you would expect to increase the risk of RSV infection. So some challenges. So there's many. Again, it's a crowded space, as we've heard, that older adults now have a number of vaccines, and when and how to get those into people is challenging. And it's a little bit similar with pregnancy now, with a number of options. The funding is perhaps the biggest one. Another question I get often, and I think it's been in the chat there, is duration of protection. So at this stage, we know it provides excellent protection for the first RSV season and seemingly increasingly the second RSV season, but we wouldn't expect this to be lifelong potentially. So it is likely in time repeat dosing may be required, but there's simply no data on that at the moment. So at the moment we say it's 1 dose, but obviously more data is coming in the future. And we just did a recent update in respiratory medicine today, so there's a bit more information in that, appreciating I flew through that very quickly. And the flu, again, I'll go through the background quickly. We know that this is a high burden disease, particularly in high risk people, including older adults and those with medical problems. We know we've had a pretty significant flu season. So this year's solid line in blue, very significant at 350,000 or so cases. So very big numbers this year. If we look at our flu vaccines, and again, this is not at all to detract from the effectiveness, obviously a really important strategy, but our efficacy varies. So there's room for improvement, and that's what I'm going to touch on very quickly. There's patient factors. So immunosenescence is another challenge, and we now have strategies for that in terms of adjuvanted high dose vaccines. Viral factors, we don't have a solution here yet, but there's lots of work happening. I'll touch on that very briefly. And there is a vaccine factor in egg adaptation that we now have a solution for. as well. And perhaps most importantly, in the sort of yellow-orange at the bottom, is the utilisation factors. And I think this year in particular has been really interesting in terms of how that played out. So just very quickly, we know that when we grow these viruses in eggs, they can change. How much and how significant that is highly variable and difficult to predict. But we know we can now grow these in mammalian cells that removes the possibility of egg adaptation. And there's an option there available increasingly to address that. And for our elderly, so immune senescence, so unfortunately, a lot of things don't work quite so well when you get a little bit older. And one of those is your immune system. And so not only increases your risk of more severe disease, but makes it more challenging to get a significant enough immune response. And so the two options we have is to add an adjuvant. And remembering adjuvants don't just boost the response, but essentially point it in the right direction as well. And then we have a high dose as well. And again, protection against the flu is highly variable year to year and in individuals, but there are significant improvements in those two strategies with no significant additional safety concerns. And of course, this is kind of old news now because these have been in place for a while. Again, just highlighting in a very busy slide, there's lots of challenges with the flu. We need to keep updating it regularly, and most of the time we get it right, but not always. And I won't have time to go into it today, but obviously there's some issues happening with the flu and in terms of bird flu and other challenges. But really, I think it's the uptake at the bottom that's potentially our biggest challenge. And if you look at the uptake this year, we've had a fantastic talk from one of our best experts about that already, so I won't go through this in a lot of detail. But here in Queensland, it's interesting. We've had a very enthusiastic health minister, and we had a discussion about this, and access funding was thought to be one of the biggest barriers. And so we were really lucky that they came on board and said, we're going to pay for it for everybody. And you can see, our numbers have been some of the lowest for some time and below a number of other states. So, while access is a challenge, we've brought on board more pharmacies, we've paid for it for every Queenslander, and yet we still didn't really achieve the desired result. So it is a complex situation. And I thought just very quickly, I'd flash up some slides from a survey the Immunisation Coalition did. It involved some focus groups and face-to-face and online surveys. The online and the phone was over 25,000 people, so pretty significant. I'm going to just flash up some of the graphs to highlight important points briefly. Obviously, people can download this readily from the website. So this was obviously before the season. Only just over half felt the flu was serious. So I think people have lost that perception of risk, and we know for people to amend their behaviour to undertake an intervention, there needs to be a sufficient perception of risk. So if people think the flu's not a problem, they're very unlikely to go and do something to prevent it. So only 29% intended to get a vaccine for a host of different factors, and predominantly in those sort of younger aged groups. So again, that was a concerning trend that came out, I guess, in terms of the data that we saw. Not providing benefit and not being important were the main reasons for that. So again, I think it's both a perception of risk of the illness, but also an underappreciation of the effectiveness of the vaccine, and some of the discussions that are more prevalent now about, well, it doesn't stop you getting it, etc. And I'm not in that high risk group, so I'm going to be fine, are all issues that we still face. And no surprises here, but it came out that COVID had reduced the likelihood of flu vaccination. And again, I think for a large number of reasons, it's made our discussions more challenging. If we move to RSV, it's fascinating, and I'm sure members of the audience have had this too. I've had a lot of people tell me we've made up RSV because we're not getting enough attention now. COVID's dying down. And of course, a lot of this is because we didn't have good figures. We didn't talk about the numbers. And now we have interventions. It's important we educate about the disease. But a lot of people didn't know what RSV was, which obviously makes trying to encourage people to undertake an intervention to reduce its morbidity and mortality very difficult. And this is very busy, but just to highlight some of the conclusions on the left. So there is still strong support for what GPs and other healthcare providers recommended. So just highlighting how important it is we have these discussions and give the right advice. But at the bottom there, you can see there's a big proportion of people who just simply weren't concerned about any of these viruses, so COVID, flu and RSV, and intended not to do anything about it. And again, I think important points to try and address. So just very quickly to go through some advances here, and again, slightly busy slides, but just to point out, mRNA obviously approved and successful for COVID. wasn't invented for COVID. Lots of work on other types of vaccine candidates even before that, and particularly for RSV and influenza. And you can see at the bottom, there's now one RSV mRNA vaccine approved in the US already. Other platforms for the flu, so protein-based vaccines have been around for a while, and there's a few candidates in that space. And one of the things some of these do pave the way for is combinations, and we had excellent discussion about co-administration, and I think combinations is potentially something that will help here, and I'll get to that a little bit later. We heard about needle phobias, and I agree. I think it's really significant, and it's really exciting. We've got some potential solutions coming. One of those is nasal, intranasal. Talked about a lot for COVID, so I've sort of left this in here to show the level of activity there is for COVID. But of course, there's candidates for flu, and one of them that, interesting, if you look at the history, has sort of been in and out of favour over time and seemingly coming back into favour a little bit. These are probably not going to replace traditional routes of administration, but maybe as an adjunct, maybe to help get some local mucosal inflammation, or as an alternative in people who can't have intramuscular injections, for example. So watch this space, lots of activity happening there. Even oral, and again, just to highlight this, a bit of a busy slide, don't look at the detail. A very challenging route of administration, been tried because of its obvious benefits without a lot of success. But there is activity in this space for all the pathogens we're discussing. And something I'm really excited to be a small part of is in people that are needle phobic, and for a whole host of other reasons. There's intradermal or basically skin patch type vaccines. And again, work has been ongoing. We did these phase 1 studies almost 10 years ago. Basically a little patch, and I wouldn't recommend showing the little micro projections to potential patients that look like these little spears, I guess, stuck to this little plate. You obviously can't see those with the naked eye. There's been various iterations of the delivery device, but this is a little patch that basically clicks this vaccine on. Some benefits potentially, in addition to avoiding the needle and syringe, in that it's room temperature stable, and there's even the prospect for self-administration. So there's lots of exciting things happening there. There's some clinical trials ongoing at the moment, so watch this space. Just to get to this, I think this is going to be one of our next big, maybe not next, but upcoming big advance, but also one of our biggest challenges, self-amplifying RNA. If we look at the commentary that still exists around the current mRNA candidates, telling people we've got one that can reproduce, I think is going to be extremely challenging. Lots of activity in this space because it does have a lot of potential benefits, but I think will be only more challenging. I mentioned how difficult it is to get high levels of consistent protection with flu, and it needs to be updated often. There's this so-called universal vaccine, and there's a lot of candidates for flu as well as COVID being worked on. This has eluded us so far, despite not being a new concept, and so I wouldn't anticipate this to be a solution in the short term, but just to show there's lots of work happening in the background. You can see how many candidates there are. So this is something to watch. And maybe even not a truly universal candidate will be successful, but just something that needs to be updated less often for things like the flu or COVID would be a significant advance if we didn't have to do that as often. And just to now come to combinations, you can see this is a slide based on next generation COVID vaccines. You can see the dark blue line is combinations, and there's lots of those that are coming through. And if you look at some of our key platforms that have been successful with COVID, there's obviously combinations with influenza coming, a sort of fairly big number of different combination options. So there's COVID flu, RSV, and there's even some with human metapneumovirus, which we haven't had a vaccine for before, that are exciting, I think. And some of these trials have been, and more will be being done across sites in Australia and New Zealand. But as alluded to in the previous talk, when to use these combinations will be really difficult, especially considering if there's more than two. But even COVID and flu, for example, given that COVID is, although some debate this, not necessarily seasonal, but the optimum time to give those vaccines will be difficult. So I know I've been through a lot in a very short space of time, and we have time for questions, but I think one of the things we need to remember and educate our patients on is RSV and the flu are very significant, particularly in the young and the elderly, but not confined to those higher risk people. We hear these terrible stories in the media and see these patients every year of people in their middle age without medical problems who suffer significant consequences of these viruses. Prevention has never been more complicated. Obviously, COVID, some recent announcements, and not the focus of this talk, but that continues to evolve. RSV, 2 vaccine options for the elderly or older adults, 1 for pregnancy, long-acting antibody for children. So our highest risk groups are able to be addressed, but not without challenges. And the flu, even though we've been doing flu vaccines for a long time, increasingly challenging new options and some more to come. Non-pharmaceutical interventions are perhaps the lowest they've been for some time. And, it has to be appreciated that a lot of us have been recommending things like staying home if you're sick at the very least and getting tested, and considering other measures to reduce transmission for a long time. It worked during COVID, obviously not suggesting we go back to some of those harsher things, but I think we're probably doing those things at the lowest level since we first saw COVID this year. And I think that's probably part of what is a complex situation, but why we've seen big RSV, COVID and flu years, as well as things like mycoplasma and pertussis. So it's a very complicated situation at the moment. Exciting times with all these new interventions available and coming. But I think if we can't address some of the issues with uptake, then obviously we're not going to see the benefit. And, forums like this are really useful, and we heard some great ideas from our last speaker, and there's no easy solution, but I think obviously if we can help with the funding challenges, educating about the diseases as well as the vaccines, and potentially coming up with some new options, maybe like combinations, then that will go a long way to helping with uptake and improve our situation. And I know I've been through a lot very quickly, so happy to take questions offline afterwards. And I think we've got some questions in the chat that I'm happy to take now. So thank you.
Yeah, thank you, Paul. So one of the obvious questions is, when is the RSV vaccine and why isn't it funded if it's so good?
You look, great question. And I think this is leading to a lot of challenging discussions, because that's the question a lot of people in the community are asking is, if you're so confident it's so good, why isn't it funded? And I think, again, it's a bit of a challenging situation. There's always a delay with funding. It's complex to demonstrate the level required, the cost effectiveness. Even if it would seem really obvious to people like us, it has to be demonstrated to people who, perhaps don't have that content knowledge around these illnesses or see people with these problems every day, to make sure that they spend the health budget in a sensible way. So that always takes time, no matter how good the vaccine is. And so hopefully this is just a demonstration of that lag in that process, and that will come soon enough. It's interesting, talked about this to a lot of providers, and the one thing a lot of people say is, don't assume people can't afford it. Don't assume it's outside of people's means. For a lot of people, this is a very important thing to protect themselves against. They might have had a relative or seen someone who's suffered significantly from it, so don't assume. And some health funds, and again, outside of the scope of this talk, and I'm far from an expert in this, but some health funds, there may be avenues for reimbursement as well. So as I say, don't assume people can't afford it, and hopefully it will be funded, but we can't say with any certainty if or when that will happen.
And you've commented on the vaccines for different age groups for the RSV, but there's kind of interesting. At the moment, Australia's only got really one choice for each age group, isn't there? Monoclonal antibodies for children, one vaccine for pregnant women, and even though they're not funded, one for older people. But we assume that soon we'll have lots of choices. So any comments on that, the fact that there's different availability for different age groups?
Yeah, look, I mean, it's obviously excellent that we're covering those highest risk groups, but obviously makes it challenging to discuss those different options, given that they are so different in those different groups. And again, the difference between what's approved and those age groups in which it's recommended, again, is a little bit hard to get people's head around. I think that's just where we need to make sure, and we heard some great resources in the last talk, that we do provide a lot of resource for people considering these vaccines. We spend the time discussing those options and the what they are and why they're recommended, and just try and educate people about the significant burden of disease and why we're so keen to do something to prevent it, and what those options are. I mean, it's been great that nirsevimab has had excellent uptake in the countries that have had it, and early limited, mostly anecdotal data suggests the uptake here is coming through fairly well, and we'll obviously have more information on that as well. But yeah, I think it's just about putting in the time to let people know what those options are.
And just to reiterate and to I think support the idea that it's the providers that need to be comfortable in recommending it. It's a question from the floor.
It's exactly a question I would have, because if I've got somebody coming in 65 plus, what I usually we've been providing our registry, because that's the vaccination that's just on the market, and also the first year we do address it to the pregnant ladies. But when would you recommend a first year to an elderly? Now that we've got two options, when do we go for treatment?
Well, Paul might want to answer, but my understanding is there's only one actually physically in the country, so they might be TGA approved, but the complexity means they may not be actually in Australia. Is that right, Paul? I think there's only one physically available for older. So the question is, when would you recommend an RSV for an elderly patient, and which one? I guess that's nuanced. Any comments on that? So someone over 50, what would you say?
Yeah, look, I mean, of course, I'm going to say go by what's in the immunisation handbook, which at the moment is recommended for everyone over 75, 60 to 74 with additional risk. So that's what I would recommend. But, you know, obviously there's some nuance to that, is that, you know, individual people might have other things that change their risk or their perception of risk. And, you know, obviously it's available for people over 60. And so, you know, that's who I'd be trying to get the vaccine to. I think I missed part of it, but I think exactly as you say, that while there may be two approved, that not necessarily available.
So, and we'll be talking later about the meeting that you get TGA approval, which talks about safety, then you get a TARGI recommendation, which talks about professionals saying they think it's a good idea, and then you get the funding arrangements, which are three different things. And a lot of our meeting is talking about how that happens, why that happens, and the inequities that causes. So I think that's something, Paul, you talk about as well, and it's part of the complexity in Australia. Do you want to comment on that?
Yeah, exactly right. And, you know, I think that all makes sense. And I think, you know, most of us understand that, but I think it's not necessarily explained. And I think, you know, that leads to that question, and exactly as we opened with, and the questions about, you know, why is this not funded if it's so good? And I think, you know, there's a process, and there's process for good reason. It takes time. And again, that's you know, perhaps a function of how rigorous it is. And, you know, I think we just need to make sure we explain that to people so they understand that, you know, the fact that it takes time for a TARGI to come up with guidelines is not an indication they have hesitation about recommending these products. The fact they're not funded is not because there's concern that it's not the right thing to do. It just, again, is a process that takes time. So, you know, I think it's about potentially explaining that, and it's not something that I think is necessarily out there as much as it should be.
So, Paul, thank you very much, and thank you for offering to make your slides available and to answering some of those questions offline. Thank you, Paul.